Hello, everybody. Good afternoon. I'm Carol Geer, and I'm here hosting this roundtable with Nupur Verma, and we have some great speakers. We're going to let people kind of get into kind of log into the Zoom. It looks like people are joining, but we're excited about this roundtable, customizing the R4 year. You know, what can we offer trainees and what should we offer them? And it seems like it's been a little bit of time since we've talked a lot about the R4 curriculum. It was a super hot topic back in 2014, 2015, when we went to the core exam, and it's going to free up some interesting educational time in the R4 year, which it really did. And we talked a lot about some different curricular ideas at that time, but there have been other things that have come up since then. It's been a while since we've gotten to talk about it. And so today we're going to bring it back up. It won't be comprehensive, talking about every single different cool thing that everybody's doing in their curriculum, but I think we've got some interesting speakers, and I'm gonna start by handing it over to someone who needs no introduction in the educational world, to Dr. Mary Scanlon from Penn. So I'll hand it over to you, Mary.
Okay, well, thank you so much. Can you see my screen?
Yes.
Okay, awesome. All right, well, thank you again, Carol, for inviting me today to participate in this roundtable. I'm really looking forward to learning a lot from everybody else and a robust conversation. So what are we here today to talk about? Customizing the R4 year. So what can we offer our trainees? Well, the world. I think we should be able to offer them the world, maximize all the resources you have at hand at your program to really customize the R4 year. I believe in a customized R4 year aligned with their career goals and expected practice environment. All right, so we're going to offer them the world, and how much should we? Well, I already said the world, but the sky is the limit. Uh, I think it's very important to customize personalized R4 with infinite possibilities. Now, this is, of course, is as long as they meet their R1, R3 goals are met for them to be a competent general radiologist and to pass the core exam. And of course, if they don't pass the core exam, then we're going to blow up the whole R4 plan and come up with a different plan. So, how do we come about with this customized, personalized R4? Well, I think it really begins with a good relationship between the trainee and the program director, really good communication, and I think a robust learning plan, a focus point of semi-annuals from the very first. So, I schedule about 90 minutes for each semi-annual, and the vast majority of the time, we are talking about their learning plan. We talk about their wellness, other issues, and at the very end, we go stoning. And sometimes I get a little afraid when I say, "Oh, it's time to go stoning," but no, we go milestoning at that point. And because I think, I'm having these conversations every 6 months, is so important, and the learning plan plays so much into it. I just want to briefly go over what I ask our residents to answer every 6 months. And it's, where are you? Where are you going? I ask them to review, reflect on their previous learning plan objectives. How'd you do? Did you achieve all those things you wanted to achieve? If not, what were your barriers? What are we going to do? What are your strengths? Ask them to reflect on 2 to 3 growth areas and 1 well-being objective that they want to work on for the next 6 months. And for each, they need to list steps to achieve that. And what's your end game? Where do you want to go? What do you envision yourself doing? And how does your R4 plan align with your career goals and practice environment? Things you still need to work on for your future career. And then how can the program help you get there? So R4 structure at Penn has been in place now for 15 years. And this has been in place since the 2010 board change. And our R4 residents are treated as fellows. They do fellow call, they go to fellow conferences. It's R1 to R3. They're doing their resident conferences that gets updated every year and a half. They hear their conference stuff 2 times before they take the core. But once you hit R4, you're in the fellow pool. During the R4 year, though, there are 5 weeks only that are outside of their fellowship, and this is where they run the show. I like to say our trauma and private practice rotations. So trauma, they're there at Presbyterian, our level 1 trauma center, and they are running the show from 5 to midnight. And then our private practice rotation is over at Pennsylvania Hospital, and they're running the show. They're there at 3, but they really are running the show from 5 to 10, and that's a smaller ER and taking care of the house, and they're responsible for all the caring for all the imaging for all those patients. So what does R4 customization allow for? Well, I like to say time in the clinic, talk the talk, walk the walk, right? So you have a resident who's interested in neuroradiology, and this allows them in their R4 year to do neuroradiology, then go on and do their traditional neuroradiology fellowship. We give them time to go and be with the stroke service, to do a rotation with them, go to the neuro ICU, work with the ENT folks, the neurologists, the neurosurgeons. I think that makes them really more value added. They know what the clinician is really looking for. Doing your internship is years before, and now you're really, you're honing your training for what your referring physician wants. And this, I think, is really important and allows for that. Away electives. Our trainees can do away electives, and having this open R4 allows for that. Just had a resident get back from France. She is interested in doing high-end MSK interventional procedures, and she worked in a clinic where they were doing just that, doing cryoablations of bone tumors, doing percutaneous fusions, cervical fusions, and pelvic fusions, and this is being done by the MSK radiologists. If this is the path you're taking, an academic career, we can give them additional research time so they can tee up their academic career. And then time to finish their tracks. Their capstone projects. We have a teach track, we have a business track, we have a quality track, a global track. This allows them also some time to finish up and actually give us their deliverables from these tracks. Time to travel for global health, and also allows for university courses, business, health policy, and so allows them to do that as well. So what have we been doing for all these years? Well, 16-month nuclear radiology is very popular here. I think we probably have more people who have done this than anybody. So we have graduated 29 folks in the last 15 years that are double boarded double board eligible in DR and in nuclear radiology. I will tell you 28 of these went on to do fellowships. One is going directly into practice. Our nuclear medicine group just recently surveyed these folks out there, and about 75% are doing nuclear radiology in their practice along with what they're doing in their fellowship, maybe about 25% of their time. Of course, we have ESR and then going on to independent IR residency. But once again, we like to try to tailor the electives to the individual in their R4 year. Have a resident who wants to be an interventionalist, who is going to be in the head and neck cancer sphere. And so he will get to go to a program in the country that is actually doing ENT head and neck interventions percutaneously. And then this I'm very proud of. Over the last couple of years, we've graduated 3 triple boarded residents. So in 5 years, we've been able to meet all the requirements. So they are board eligible in diagnostic radiology, in interventional radiology, and nuclear radiology. I think this is sort of spectacular that they can circumferentially care for that oncologic patient. So that patient is theirs. That patient is there in the IR APDR suite, and that patient is there in the nuclear medicine clinic. I'd like to do more of that. So our R4 customization allows for super subspecialist to subspecialist to private practice. And if we want to look at our super subspecialist, that's what I was alluding to before. In your R4 year, you start your MSK, you have all those opportunities to get in the clinic, do some research, and then you go on to your MSK traditional fellowship. So I like to say that really makes you the super specialist. The subspecialist is such that they do an R4 concentration in one area, and then they go do their fellowship in another. So they're really subspecialized in two areas. And then private practice is where we let them in their R4 year do half a year in one thing, half a year in another. Then they go on to a fellowship. And I think that sort of meets some of the things like the ACR surveys have shown out there, that folks out in private practice, you may actually concentrate on three things. They may be doing a lot of general, but they may be asked to be doing three things, and this lends itself very well for that. The half a year, and then a full year. So that is three areas that they're very well versed in. So most general, we've previously allowed our trainees where to split the year up into half. We didn't allow them to be any more general than that. And we called that sort of our private practice tract. But now we are back to the future. And with that general oral exam, we have now said, yes, you can be a generalist. You can spend your R4 year in blocks of two and basically do six areas. And that's our general radiology training, if you will. So we've been offering that since the board's switch. And of course, we have our mini concentrations where we break the year up into two things, and our macro, which is 11 months. In light of the new boards, we have new R4 opportunities. We have an elective and procedures expected of a general radiologist, so they can go back and retrain and reconnect those synapses. Of course, using our procedural modules, the one task force came up with to help train for that. We have an elective and MSK procedures that they can do. And then this is something our trainees have asked for, is remote voluntary evening shifts. They want to do more. This is to keep up their general skills in light of everything that's going on. So just to say now, bam, let's kick it up even more. I love cooking. That was my other career choice, was to be a chef. But I figured the hours were better. I don't know about that. We do have our R4, and we've always been calling it like a macro concentration for 11 months. But I will tell you, for the last couple of years, we've been calling it an R4 embedded fellowship. And our trainees are actually getting a certificate along with their DR certificate that says R4 embedded fellowship in this. And so they have that to take away with them. And we have trainees now that are going directly into practice, directly into both private practice and academics after they graduate after 4 years. Not necessarily what I wish for them, but this is the way it is. I prefer everybody to do a fellowship, but you know what? The market is such and that it's out there. In 2023, we had 2 trainees leave to go into practice after their R4 year. 1 breast private practice, 1 body in academia. I do tell the residents who are going into academics, I'm like, don't change your job for 5 years. Make sure you stay there doing that body thing, so you are really recognized as an expert after years in that position. Don't flip-flop around. 2024, we had no takers. This year, we have 4 residents out of our 13 that are going directly into practice after their 4 years of training. And 2 are going into breast, 1 into nuclear medicine, and 1 going into MSK, and that's academics. And next year, we're on target for one going directly into breast and one going into industry. So basically, just to recap what I said, customizing the R4, what can we offer the world? How much should we? The sky's the limit. And thank you so much for listening to me for these last couple of minutes. So there you go.
Thanks so much, Marion. You answered one of the questions. Sounds like you have 13 residents a year. That was one of the questions that got put in. So with that, and again, I probably should have said at the beginning, questions just put in through the Q&A, and at the end, we'll get to those. I'll hand it over now to Dr. Ryan Peterson at Emory.
Thank you very much. Today I'll be talking about different tracks that residents can do. Come on. Unfortunately, I'm not being paid for this. I have no financial disclosures. So a lot of our residents, they come from different walks of life, different backgrounds, different paths, and we put them through the machine, the ACG machine, where we have a standardized curriculum. We want them all to see the same thing, be tested on the same thing. And you know what? Sometimes it feels like they're coming out as donuts, maybe really, really good donuts, but just all looking kind of the same. And sometimes, that can lead to residents and sometimes the future faculty being burned out or lack satisfaction with their career. So I'm here kind of today to say, like, there are different pathways in residency that you could go along. And I like to say you can make that a different flavor or topping of a donut. And so today I'm going to talk about different ways you can have in your education pathway, the design considerations for these tracks, and tips and tricks for maintenance of these tracks. And, we're talking about R4 year. And I think this is something longitudinal that we do, but it's something that can be really focused on in their R4 year. Now, we really want to train really excellent radiologists. And we do things like, mini fellowships. We're in our program, we're starting to do 2 mini fellowships. We have all these different options for residents to go into. But there are some other pathways besides fellowships and clinical rotations that residents can do. Here at Emory, we have sort of 6. And Dr. Scanlon sort of has sort of the same ones, but we have global health. We have a molecular imaging, with that dual certification pathway, informatics, quality improvement, clinical education, and research. Now, with the basic design of these pathways is that it is a longitudinal. It's from baby radiologist R1 up until their R4, but they can get a lot of this stuff done in their R4 year, okay? And there's 3 different pillars to that. And sort of as a basic structure, we have small group series that they participate in every month. They have practicum where they're actually doing what they're learning about, and then a capstone project. Now, we give them 1 academic day per month in the track to perform these duties, get together as a small group. We require them to attend. We use these meetings for teaching or doing their capstone projects. And if they don't show up and they abuse the system, we have some consequences for that by losing vacation days. But sometimes there's opportunities that come up that they can get some extra time. So the capstone project is one. It's a longitudinal project they do through their entire training, something that's tangible, something that, like a paper or a new curriculum or whatever that is, something that they can present at a national conference. We also want to practice what they're learning, whether that's in the education track, learning, teaching students, or participating in real life informatics projects, things like that. So I'm going to take you through some of the different tracks, but this is the one that we have a separate match for. People go in from medical school in there. It actually has protected research time. Even though we don't have a T32 grant, you can treat them like they are a T32 and have that research time. We have mentorship, and we've had a lot of success with our residents actually getting RSNA grants and other grants to support them. Now, there's 3 of my knucklehead trainees, but they're doing things like going out and looking at AI approach to teaching radiology, or using AI to go through different our reports to see if there's corrections or mistakes using AI software. They're doing things like going out and talking about how to give automated feedback to the resident from using AI and different things. I even have a resident that's really big into designing catheters, like monitoring sodium, potassium in the tip of the end of the catheter that they place. Even creating kind of their own company and going out and winning like going to the RSNA Shark Tank and performing that kind of stuff. And also mentorship. And it's not just from faculty to our resident, but as they get into their 4th year, having them mentor medical students. This is one of my residents. He's going to stay on here as a neuro faculty. He's mentoring many medical students in his R4 in his last year, and that's an opportunity for them. We also have the molecular imaging pathway. You know, it's essentially you get a DR and a nuclear medicine fellowship. I thought that was amazing. The triple board certified residents you have, Dr. Scanlon. There's a 4 or 5 year pathway. This is for, you know, not just for academic institutions, but, you know, large private practices will look for this kind of thing for residents. And there's a lot of residents that are interested in this, and you get the certification in both. Now, again, it is a lot of research. It's a lot of time in the lab, but our residents really find a community with our nuclear medicine department. Global health is one that I find that residents are very interested in. You know, it's focus on becoming stewards of global radiology. You know, during the track, they're designing and executing global health projects. And like Dr. Scanlon said, in the 4th year, that is a time to go out and actually go to the country or the area that the resident has been designing these projects for. It's looking at access for international, but also we call it local, or the locally underserved populations as well. And the nice thing about it here is that it aligns with a lot of our School of Medicine pathways and the department. So again, you know, they're doing a lot of ultrasound. They're doing hands-on. The upper levels, the R4s are teaching the junior residents how to do biopsies in ultrasound, or like honing their ultrasound skills. They're out in the countries using these. They're out teaching the residents at these other institutions, because it's a very different environment, different pathology. So you can share information, and it's a wonderful way for our residents to go out and teach as well. Be in the reading room with these residents. But it's also a good way to go out and see the world. We have a great relationship with Black Lion Hospital at Addis Ababa, and they get to see the world, experience different cultures. We have residents that go to Tanzania. And then, you know, this is that global I was talking about here. We have a thing called Clarkston Clinic. We provide free support to this refugee kind of encampment here in Georgia. And so it's a way to perform those skills and help this community as well. We have this group will be participates routinely in Rad Aid. And, you know, finding funding is always a fun thing to do when we try to encourage our residents early on in their residency to go out and find that funding to help provide for their projects. Quality improvement is another one we do. You know, it prepares residents for being involved in that QI space when they get out of residency. You know, the curriculum is both inside radiology and outside, and building those relationships with the hospital, because there's a lot of quality improvement projects going on outside of radiology. You can use GME courses, you can use patient safety courses that might come through the School of Medicine, but we really try to focus on radiology specific sort of activities. And they'll get together, they do things like looking at our reports and using Google Translator to translate it from something that I talk about oncovertebral hypertrophy to what a normal lay person would understand the report to be, and just making sure that patients know what their reports say. They go out to RSNA and they share these kind of things. So in their 4th year, they have a lot more time to do these kind of projects and finish their projects. Informatics, you know, it aims to improve efficiency in their imaging system. You get some further qualifications to navigate some of the tools that we use in radiology. It's both theoretical and hands-on, and, you know, it fosters some leadership and scholarship. Now, like when you're talking about like informatics, it looks like a crazy hot mess like this, and they're working with the informatics people to make it more efficient, to understand having the physician there to understand what does a radiologist need. And so they'll participate in IT meetings, they'll go to small group of discussions, mentorship, and, you know, just completing some projects. They actually get some deliverables. They'll complete the Epic Physician Builder. They'll get that certificate. They'll often get the book and take the test to be a certified image informatics professional. And so all of these things help with that. And, you know, there's other labs that talk about AI. We have here If you have any opportunity to work with another institution, like here in Georgia, we have Georgia Tech, which is a very big engineering school, and just getting them out in the world and publishing about what we're doing, getting them to talk at SIM, like there are conferences. And there's a whole list of career opportunities if you want to be a CEO of a company or even just be informatics chair of like the school, not just radiology, but at a hospital is important. And kind of the last one is, you know, my love, clinical education. It's building the future educators, not just for academics, but private practice. And you know what? We have small group series talking about different topics. You know, we get together and share. We want them to teach. So there's many opportunities to teach and do that practicum. We have like different capstone projects, like our R1 curriculum is basically run by our residents and it was designed by them. We have medical student training that happens with them. They go through and they build different devices and like teaching kind of things using, you know, Oculus and other things. But there's a whole lot of different things that they've done. We let them participate in our faculty development programs as well, which is good for them. So how do you do this? Just real quick, you know, one step at a time. You got to figure out what you're good at, sit down and think about what opportunities your program would have, and look at the resources. The first step is to sort of build a team, okay? And you know, we think a faculty is going to be the team member, but junior faculty have a lot of like energy to get this done. You like having a team of both advisors, senior faculty and junior faculty is really good, but you need to have it resident run, okay? And you need to have somebody that this is their torch. They're going to go out and really help the residents, sort of guide them, okay? Build those bridges for them. And, you know, I couldn't do this without all these different faculty advisors. Something we did recently is, you know, I made a track director, somebody to help coordinate between the different tracks, have standardized reporting, make sure everybody's doing the same thing. And you need to make sure that track director gets acknowledgement and awards. I mean, and things that will help them in their academic performance. You need to have a succession plan. Like 2 to 3 years is probably the lifespan of one of these track advisors. So you need to plan out ahead of time. You need to make sure that the tracks, like all the residents, aren't going to be on their academic day at the same time. You need to go through and make sure that you're tracking the residents that are in the track, that they're being productive, and make sure that they're being held responsible for not performing or doing the thing that they need to be. This is something extra that somebody can do. Okay. You need to find mentors. You need to find financial support. But you need to get buy-in. And that things that you do to get buy-in for these kind of programs is get the residents out there, get them presenting at either grand rounds or out at, you know, their posters at different conferences, or even like get into AUR or AR now and get other people involved, people that are not in the track, get them to come talk to small group series, get them to talk to the track residents. And, you know, it's been a huge, like, recruitment strategy for us because the applicants want to do this. And it's a great pipeline for future leaders in radiology. So the things that are future is, you know, global health. We're actually in July, we're going to start a new track, the business in advocacy and healthcare policy track. And so the only other thing that I have is that we, like Dr. Scanlon had, we have an accelerated pathway. So we try to really find really clinically strong residents that want to fill hard to fill subspecialties. They have the last 6 months kind of blocked off, that they're in a fellowship, and then they become a clinical instructor in their fellowship year. Again, it's kind of a weird place to be, but there are some places where this is important. So finally, you know, there's many potential avenues. It's a great recruitment tool, and you know, it's a great opportunity to capture future radiologists. So thank you very much.
Thanks so much, Ryan. We'll move to Nupur Verma and Scott Berner, and then we'll at the end circle around for questions. But if you have questions, please just put them in the Q&A, and some of our speakers can sort of answer some of those on the fly.
Thank you. Good afternoon, everyone. My name is Nupur, and I'm here with my colleague, Dr. Scott Berner. We'll be co-presenting for the next 10 minutes. I will be speaking about a call for generalist training. We learned about some excellent tracks and opportunities. We'll take some time to reflect on refocusing on generalist training, even in the fourth year. And then my colleague, Dr. Berner, has some interesting experiences to share on how generalist training can be a hero in times of incredible need in radiology, both in day-to-day staffing, but also in moments of crisis. So starting off with considering why we focus on generalist training, overall, we all accept that there's a radiologist shortage and subspecialization trend has been increasing. This data on the right-hand side is a little bit older, but there is a recent JACR article by Dr. Duzak, which releases the 2024 occupational survey, and that shows majority of radiologists still identify that they're working in generalist practice, over 55%. It also validates that both breast and body imaging are the highest hiring needs in our job market, and it brings to light two important considerations. Majority of radiologists do prefer to stay in their current work position for the next 5 years, but at the same time, 16% plan to seek new employment in the next year. That tells us that radiology is in a constant flux of staffing. When thinking about how generalist training can help our radiology staffing, it's important to also think on a little microscopic level of how your practice is functioning. So I want you to step back and look at radiology and reflect on what the generalist training does in your group practice. A lot of radiology practices have embraced teleradiology, with over 58% allowing for teleradiology practice in private practice. So the generalist radiologist is the boots on the ground, and they need basic procedural skills: thoracentesis, paracentesis, and lumbar puncture, perhaps even fluoroscopy. They may be asked to step in with a consultation, for example, in pediatric imaging or MSK as well. And as Dr. Scanlon spoke in her presentation, the APDR task force on procedures expected of general radiologists has addressed this gap by having some impact on American Board of Radiology in bringing back the oral board exam. There's also an evolution of radiology practice that is day-to-day. There's a granular volume or flux which changes. For example, on one day, you may have your only pediatric radiologist out sick, or you may have a shortage of breast imagers, and you may have to require some of your radiologists to flex into that staffing position. The number of radiologists also has an incredible effect on whether or not generalist radiologists are needed in a practice. Subspecialization works well in large academic institutions. However, the average private practice size in the US is between 30 to 45. And in that situation, it's hard to provide subspecialization 24/7. There's also a change in radiology preferences over time, as well as a mix of radiology preferences on a day-to-day work environment. Some radiologists may prefer, for example, to read only in the evenings, where they're working more in a generalist role, staffing emergency department exams. Other radiologists may prefer to do subspecialization on a per diem basis or a per click basis, which would allow them, for example, to read only MRI exams. The other factor that is always in the back of our heads when we're working is that staffing instability can be everywhere. And we particularly learned this during COVID, dealing with coworkers that might be sick, might have childcare demands or other demands that take them away from the workforce, either temporarily or on a long-term basis. So where is the breaking point for staffing, and where does the general radiologist play a role? Standardization leads to rigidity. So if a radiologist is only willing to read a particular type of exam or a particular type of modality, it can be very hard for a practice to function during a time of shortage or in a time of practice change. So consider how flexible your group is. There's also a component of burnout, which comes into play when you ask radiologists to do things that are outside of their expectation. So for example, if a radiology resident has an expectation to be a super subspecialist, then asking them to be a generalist a couple times a week or a couple times a month in their first job can lead to a sense of burnout, because their expectation was to do a subspecialty career pathway. So it's important that expectations and group sizes, considering how different practice days might be handled, is really a part of teaching residents to expect whether or not generalist training is important. So how do we approach residents to accept generalist training when we have all these wonderful, very attractive tracks? One of the important concepts can be framing the generalist training. So generalist training is often considered common. Perhaps it's something practiced by radiologists that are later in their career, or only by certain radiologists like emergency radiologists. It's important to frame to residents that we are all generalists. Even those of us that are super subspecialized, the reality of our workforce and the reality of our work is that we are practicing in an environment where we cannot be very siloed and where we are forced at different levels to either practice in other modalities or in other subspecialty areas. And I think that framing concept is really important to help residents feel a sense of early career satisfaction and to help that first 5-year period and make sure that they're able to maintain that expectation during their job. We also have to consider that subspecialization, although very elite, very attractive, is something that can be balanced with generalist training. And it's something that we have to worry about when patients and our staffing models are requesting that care be provided 24/7 with an ever-increasing volume. So how can we do that? I think Ryan's approach, Dr. Peterson's approach of selecting residents and having them have a portion of a say in what they get to specialize in is excellent, as well as a combination of what Dr. Scanlon presented, where there's set time periods for specialization, as well as protected time for generalization within the R4 curriculum. Now, Dr. Berner will share how generalization training has been a life-saving service in times of crisis and needs by sharing his experience during the hurricane.
Hello, everybody. I'm Scott Berner. I'm, like she said, a radiologist here in Western North Carolina. Thanks for letting me join the discussion today. I'm going to give a brief overview of our experience during Hurricane Helene and then highlight a few of the benefits of a strong general radiology background. So this is kind of a collage of pictures from early on. We knew there was a storm coming. Typically, though, they go a lot further east and we just kind of get the leftover rain. But as I'm sure you all know, that didn't happen this time. While we still had cell service, we got an email with that image in the lower left showing basically every road in the county was closed, every interstate in and out was closed. And then we lost cell service and couldn't talk to anybody, and most people couldn't leave their homes. So these other images, the one on the left there, that's my street that my driveway connects to. And then the next three are kind of where I eventually met barriers trying to go 3 different ways to get to 3 of our different hospitals immediately after the storm. And so everybody had no communication and was basically just trying to get to the hospital whenever the water went down enough to where they could. We did have one radiologist who got stuck going between 2 hospitals during the flooding and had to take shelter with strangers in their house. And we didn't know where she was for the next 48 hours. There was a lot of that, just lack of communication. You can go to the next slide. So each hospital, as far as the hospitals were going, they were running on generator backup, no running water, no functioning plumbing for several days, no cell service, and definitely no PACs. Didn't have air conditioning, so because you didn't have water for the chillers. And so one of my CT rooms was at 86, 87 degrees, and the scanner kept overheating, and basically everything was a mess. The radiologists and other staff who did make it into work, we went to downtime protocols, paper charts, read straight from the scanner, paper prelims for, in some cases, weeks. The main difficulty was lack of communication, figuring out who could go where, when the radiologists who were working could be relieved. Same with the technologists. A few of them lost their homes and they graciously stayed at the hospital and kept working in spite of all of that. And they would take 12-hour shifts, sleeping in the PACU, and then come right back to the other part of the hospital, come to work. Some of our regional hospitals were not accessible by car for several days. So the main hospital was flying radiologists on a rotation of 24 to 72-hour shifts to these hospitals, 1 radiologist at each one. One of the harder hit areas had a FEMA hospital next to it, next to the regional hospital, which is what you see in those other 2 images there with the tents. Those providers were from out of state, but they got emergency credentialing and were able to order studies and use our imaging facilities. After communication started coming back online, it was still taking up to 10 hours, for example, for a code stroke to hit PACS. And so obviously that's unworkable. So we still couldn't send anything centrally to our main hospital. So we had to have a radiologist on site at each of our 7 hospitals, 24 hours a day for at least a week, and in some cases up to 2 weeks. Rather than our usual, 1 to 2 people we have covering remotely during off hours. So that puts a big strain on the group pretty quickly. We're really thankful for everyone's flexibility, and having a generalist background was critical in being able to keep staffing these hospitals. You have to read whatever comes up. You don't have your usual reference resources, no internet, no communication. You don't have your colleagues that you're used to working with. Basic procedural skills became very important. A lot of our lighter IR cases, neph tubes, chest tubes, that kind of thing, stayed at the regional hospitals because they couldn't get transferred, and those procedures would have to be done by whichever diagnostic radiologist was there. The images on the right were some of our radiologists who were not at the hospital or were off their shifts, using a different general skill set, clearing an endless amount of trees. So we were really grateful for them helping their neighbors and everybody in the community while they weren't at the hospital. You can go to the last slide. So while this is an extreme case, it does highlight the importance, I think, of flexibility in a radiology practice. It may not be a hurricane, but any group is going to have situations arise that require flexibility, as we touched on earlier, unexpected illness, retirement of multiple partners at the same time, paternity, maternity leave, that kind of thing. And the current radiology shortage makes these situations put even more of a strain on a group, particularly small to medium-sized groups. My group, before we merged with the Asheville group, had several of these difficulties with people who had retired, and then we'd have gaps in subspecialty coverage for months to years at a time, and people would kind of have to flex in what they were expected to do day to day. We're now around 60 radiologists and a few vascular surgeons in the group, and even though we're a bit larger, every radiologist still participates in the general evening and weekend coverage, some in nights if they choose to. Every hospital, even our regional ones, have fluoro, mammo, IR needs, and having radiologists who are capable beyond their subspecialty really gives a lot more flexibility in scheduling, which I think is a huge driver in job satisfaction. Even in subspecialized academic practices, from some of my colleagues that I talk to, a lot of times new hires are expected to pick up unfilled shifts in other departments. So with that said, I think that kind of highlights the importance of general training remaining the main focus, or at least a large focus, all throughout residency, and then obviously followed by subspecialization and fellowship. It'll help your residents with a job search as well, if they're not immediately limited to just their subspecialty right out of the gate. So that's all I got.
Thank you, Dr. Berner. I echo that. And I think also, even for the individual resident who's practicing, as your life changes and your life stage changes, perhaps your geographical needs to be in a particular location or practice teleradiology, being a generalist is not just beneficial to the practice and to the patient population, but it can be very beneficial to the trainee themselves as their career needs transition. Thank you.
Thanks, everybody. Those were incredible presentations and have brought up a lot of food for thought, some very innovative programming, but also I appreciate Dr. Scott Berner sharing some of that imagery from Asheville area, because, one of the things that Scott had shared with me before this roundtable was some of the very subspecialized folks were actually not very helpful in this situation because they weren't comfortable and hadn't read some of the stuff. I have to own, I'd probably be one of those people because I'm a neuroradiologist and I'm very subspecialized. And, while some of us are going to work in some very subspecialized practices, I think the data that Nupur Verma showed is a lot of our residents are going into practices where they are going to need to feel very comfortable and solid as a generalist. One of the questions I have, for Dr. Scanlon, I thought that was really interesting. One of my questions was, do you have that 5 weeks built in, which I think of as sort of, if I'm understanding it correctly, as a generalist training, really? Do you think that's enough? I'm going to say in our program at Wake Forest, we do a lot more than 5 weeks of generalist training, and I almost think sometimes it isn't enough. But what are your thoughts on that? Do you have to kind of watch pretty carefully? These folks are basically spending most of half the year in one thing, half in the other, and getting really good at those. But just sometimes you have to maybe force someone into the other pathway that you're doing where you're doing a couple of months just to make sure that their general skill set is solid.
Right, well, we also have 11 months where they're just doing one thing, but exactly right.
Yeah.
That's why we have the 5 weeks where we're doing that. That's why we offer electives and procedures expected of a general radiologist. And I will tell you, our first 3 years are very focused on those procedures expected of a general radiologist. I mean, so they know how to do those 10 and they're expected to be competent in that, and they are, and then they can retrain it in their 4th year. That's also why we have this extra call, voluntary evening shifts that they want to do. So like, I really believe that we can train people to be both generalists and specialists and that they can do it. And that's the mindset that I like to have them leave here with, just for that same thing. Frame your training, so they don't get burnt out when they're out there in private practice and maybe 1 or 2 days a week they have to do general stuff, or they may have to do a thora or a para, at that clinic. So yeah, I think we do it.
Yeah, I had one other question I had, and again, if other people have questions, just go ahead and put them in, but I wrote down some for the group, Do you have some, it sounds like rotations where, you could take some course at the university, go out of the country. Do you ever have any troubles with your GME office with that? Just because, they're paying your residents salaries. And did you have to work with GME to make those things happen?
Well, I'll tell you, the extra research blocks that they do, the department has to pay for that. So
Okay,
whenever
that's
they
what I was
run
wondering.
research, the department's paying for that. We have not had an issue with outside electives, nor have we had issues with global electives.
That's very interesting, because that's some of the things I think some places, depending on your GME office, something that you'd really have to talk with them about, because they can get different GMEs have some opinions on that. For Dr. Peterson, there's a question in the chat that asked to describe the schedule of 3 residents at Penn who are able to complete the DR, IR, and ABN in 5 years.
Well, why don't you give me your email address, because I'll send it all to you because it's quite the tour de force.
Yeah,
So
sure.
I don't want to. I'm not gonna be able to do it justice by like rattling it off the top of my head.
Can you send it to me too?
Yeah.
Send it to me too, please.
Yes, sir.
Yes. I have one for Dr. Peterson though. So when do the residents decide that they want to be in a tract, and is there competition to be in a tract?
Yeah, so we have sort of a parade of the different tracks during their R1 orientation when they come in the first week. We have a common sort of application, and we sort of have, it's almost like a rank. Like they list the ones that, like, I don't want to have a resident in more than one track at the same time. The only one I allow is if they're in the molecular imaging, the dual certified clinical track and a non-clinical track. That is okay, because a lot of the elective time in that molecular imaging pathway is in their 4th year. And so my czar of tracks will go through and work with the different faculty advisors to see who they want and sort of try to get residents into the right space. Now we've had people drop out of track eventually later on in the down the line, but it's actually pretty rare. Sometimes I've had to ask residents to step down from a track if they're not performing clinically well. But it's usually people stick with their track along the course.
So
One of
at
the
Penn,
questions. Oh, sorry,
was
go
gonna say,
ahead.
At Penn, all our tracks are introduced during HIT-BAR. HIT-BAR is our course, a 2-week course, how to be an awesome academic radiologist. That's usually in January, the first week. All the tracks are presented at that time, and then there's an application, and then they decide, and not all residents have to be in a track, God knows, right? And I'm sure that's the same way at Emory. So that's how we do it. And informatics is a track that everybody is an add-on, because that's an R4 just block, an add-on to any of the tracks.
Yeah, right. That was a question in the chat for Dr. Peterson. You know, are there residents that are not in a tract at all?
Yeah, I'd probably say about 40 to 50% of our residents are on a track. There's about 1 to 3 residents in a track every year, per year. Well, yeah. So I'd probably say about 50% of my residents are on a track. Now we've always talked about a general practice track as well, but we haven't done that yet.
Yeah, and for Dr. Scanlon, it sounds like that's what you've added recently seems like more of a general practice track where you do 2 months and 2 months and 2 months and 2 months.
Exactly. That's all with the new board change. We added that in. So absolutely.
And again, I would say that one of the things Nupur Verma and I've talked about is, not all residents are, learn at the same growth level. And I think that, the data that Nupur Verma and Scott Berner are putting out there, I think it's very attractive to do many fellowships and or concentrations and different academic tracks. But the reality of it is, I think Mary Scanlon said this at the very beginning of your talk, which I think was very important, is to have that meeting with these R4 residents about what are you thinking about career-wise? Because if you are already thinking, I'm going to probably go into a practice where I'm going to do a large amount of general work, that there are R4 maybe should be very focused that way.
Yeah, I think to comment on that, the first point, career pathways and many fellowships, I think, are very, very attractive to the applicant pool. It is certainly a very common question among radiology applicants, and I think they do view it as a high favorable aspect of a training program. At the same time, career-wise and, considering, I think residents need to be, I wouldn't say told, but understand the perspective that our careers change over time. And, it's something that you may not want to change because you don't want to relocate your family or because you are in a position where you are in a practice for several years and you are tied down due to financial constraints. But our careers have to flex. And I think they do have to flex every 5 to 10 years or so. But going back to whether or not residents desire subspecialization, I think it's become a very hot topic and it's become a very desirable trait in a residency training program. And we have to balance that with providing the clinical service, but also providing availability for faculty. Dr. Peterson has several faculty that he keeps engaged. And I think one of the important things is he realizes these faculty have a 2 to 3 year service period on average before they kind of burn out of that role, or maybe not burn out, but they're ready for a new challenge or a transition. So, even providing the infrastructure requires a large pool of faculty, extensive financial resources, curriculum planning, which is I don't even know how it gets done, but amazing curriculum planning, amazing scheduling. So there's a lot that goes into providing these exceptional tracks that have been presented to us today. All programs may not be able to provide these tracks, and that doesn't make them any, more or less superior, inferior. And I think some residents may feel that where they have matched, they're not being provided opportunities that they were looking forward to in the interview process as a whole. So it's important to have these kind of conversations one-on-one with residents to help them understand the training is not the beginning and the end of your experiences. Your experiences will come during the workforce, and your experiences and your desires will change over the next decade plus. The average retirement age for radiologists, according to the 2024 survey by the ACR that was published in the March 2024 JACR, is 75. So career longevity is at an all-time high. And during that, there will be several periods of transition, several opportunities to pick up new tracks. They won't be called tracks. They'll be called on-the-job training, but they will be there. And, I think that residents have to keep that open mind. The fourth year period is not the only time for growth and change. I think we're continuously growing and changing during our careers. And hopefully that quells a little bit of resident disappointment if they don't get to participate in a track or alleviate some pressure of having to do that in the fourth year period.
Yeah, Ryan, you had your hand.
Yeah, no, I was thinking about, we talked about the general radiologist and the ER environment. I was lucky enough when I came out of fellowship to be an ER radiologist for 2 or 3 years before I went back to neuro. And like having moonlighting opportunities for residents in the emergency department, that is a whole lot of different things, different subspecialties coming at you. It might not be like cancer imaging outpatient style, but those are providing moonlighting opportunities, not just like the volunteer. I wish I could get my residents to volunteer for extra shifts.
They
But
asked for it.
I know that's amazing. But moonlighting opportunities for residents because the volume is so getting high and high, so much complex and higher now that the residents being able to do moonlighting opportunities, I think, is a great way to train and keep the general radiologist at heart.
Yeah, Mary.
Well, I just want to say that we are lifelong learners, and that's the most important message that I give our residents is training does not stop with your residency, does not stop with your fellowship. You're going to learn. I mean, listen, guys, I started where a CAT scan was 6 images, right? A stroke alert was 6 images, and that was back in 1980. I had to learn all that along the way. We constantly are learning, and that's what they need to know.
Yeah, I think those are excellent points, and I think that I hope that people on this round table are sort of, when I was listening to Mary Scanlon, Ryan Peterson, and Nupur Verma talk, I'm thinking, oh, some of these things that I haven't done in my program, I might be able to do. Depending on, to Ryan Peterson's point, you have to look at what expertise you have in your own place. And I hope, what folks are getting out of this, oh, there's some interesting things that you might be able to do in your program in the curriculum that you already have going, and not, I agree with Nupur on the questions, like the scheduling that Mary and Ryan, y'all must have to do to make this work has got to be a little bit complicated.
It would be the chief residents.
The
Well, there
chief
you go.
residents. I help supervise the chief residents, but
Well, there you
That's
go.
right.
they
God
know
bless
the
our
system.
chiefs.
Yeah, I know, right? I agree.
Yeah, that's an excellent point. There is a one more question in the chat for what would a typical and I actually had the same question, a typical R4-year schedule for someone who's not in a track.
I mean, everybody gets at our program, like we're starting next year doing 2 mini fellowships that, I mean, we like to block it off. I don't know if that's going to blow up our schedule or what it will do. We try to block off the first mini fellowship, and then the second one is they might not get the full 12 weeks kind of thing. But I mean, the typical is just electives of whatever they choose. Like I remember when I was back in the day, I have some pet. I do some things that I thought I would do with my life. Some very generalized things. You have to do the nuclear medicine requirements. You have to do the breast requirements. But again, you still have to take call and fill in the gaps of clinical service. But again, a lot of it is elective time for and generally it's a broad range of things. For us at least.
Yeah, that's helpful. I was wondering the same thing. I'll say, like at our program, all of our R4s have to do some fluoro, GIGU fluoro. Not a lot.
Despite all their protests.
But it's one of those things that out in general practice, if you talk to the Scott Burners of the world out there, you got to do some of that. And it's just sort of little refreshers on some of these things that don't necessarily fall into someone's specific subspecialty all the time, like body MRI maybe, or some things like that, that we kind of all have to be able to do potentially, especially if you are in a private practice setting. So some things to think about.
I can confirm there is definitely enough fluoro to go around. Yes.
No, it's everywhere. Yeah, so I think at this point, I think we're right at 12:59. I just want to say a huge thank you to Dr. Mary Scanlon, Dr. Ryan Peterson, Dr. Nupur Verma, and to Dr. Scott Burner for presenting these. It certainly, it was very helpful to me. Y'all have given me some really good ideas. Amazing programming. I mean, kudos to you all for the thoughtfulness of the presentations, but what you're doing for your residents. It's really pretty awesome. And I hope this sort of spurs maybe some more conversations to be had at AAR as we move to the oral exam, and probably some more adjustments to our R4 curriculums in that way. But thanks to everybody for joining.
Thank you for
Thank
the
you.
invite.
Thank you so much for having us. It was wonderful.
Thank you.
Yeah, everybody have a great rest of your day.
Thanks.
Bye.